I'm Dr. Pradnya Gijre. Let us see how to manage a case of heart disease during pregnancy. The common conditions encountered are congenital heart disease and rheumatic heart disease in the younger population. Cardiomyopathy is seen across all age groups. Myocardial infarction, ischemic heart disease, and aortic dissection are more common in the elderly population. So essentially, all the pregnant women attending antenatal clinic should be examined thoroughly with a proper history and auscultation of the heart and the lungs. High index of suspicion should be kept, and early referral for ECG, echocardiography, and blood biochemistry should be arranged. A multidisciplinary team should examine the patient for risk stratification at the earliest. Frequent visits should be organized 2 to 4 weekly for the first half and 1 to 2 weekly thereafter. At every visit, a history of orthopnea should be sought. The rate and the rhythm of the pulse should be noted. The heart sound should be auscultated, as well as the lungs should be auscultated from behind for presence of Krebs, and oxygen saturation should be noted down every visit. Mitral stenosis, pulmonary hypertension, and tachyarrhythmias need to be tackled promptly and monitored closely throughout the pregnancy. Antibiotic prophylaxis should be considered in those with a valve replacement whenever required, and a low threshold should be kept for thromboprophylaxis with aspirin and low molecular weight heparin injection. A multidisciplinary team should decide or formulate the line of management at the time of delivery at 30 to 34 weeks, taking the patient into confidence and counseling her and educating her what to expect, whom to approach, and what history to tell at the time of delivery. Minimizing the load on the cardiovascular system is the aim at the time of delivery, and it is achieved by ideally allowing the spontaneous onset of labor, cutting down the second stage of labor by assisted delivery, and adequate pain relief. Prophylactic antibiotics should be considered wherever required. A senior and experienced team is needed at the time of delivery. Avoid excessive bleeding, avoid bolus dose of Pitocin IV as well as methergine. Misoprostol is the drug of choice here. At the time of seizure, consider compression sutures over the use of eutotonic agents. After the delivery, the patient should be closely monitored for the 12 to 48 hours and up to 2 weeks in case of pulmonary hypertension and cardiomyopathy. Thromboprophylaxis should be restarted, and one should delay shifting the patient on oral warfarin to avoid delayed postpartum hemorrhage. Postnatal checkup should be arranged at 6 weeks and 6 months as a routine. Contraception with implants and hormone intrauterine system is preferred. For the permanent method, vasectomy is the first choice, followed by minilab TL and hysteroscopic tubal blockage. So this is in short an outline of how to manage a case of heart disease during pregnancy. Thank you.